sunshine to keep you awake or inspired. So hopefully my lecture will do that a little bit. How many people here are from San Diego, by the way? Chris Walensky. He's what do you call those? An import from Massachusetts. He's opening a practice in April 16th. Is that right? At least that's when you invited me. You might have invited the other people earlier, huh? Yeah, so welcome, Chris, to San Diego. But San Diego is a great place, as you can see from the hotel we're in and the nice views outside. And fortunately, there's a lot of great patients in this city, too, and I've had the fortunate experience to be able to treat some of them. So I'm going to share my experience with you today on that in terms of how a laser affects my practice. And my practice is geared towards cosmetics, but we do general dentistry for adults. And so we'll use all kinds of different modalities to get to an aesthetic result that might include general dentistry and orthodontics too. So you'll see that today, and hopefully you'll learn something. But as I go along, if you have any questions, feel free to stop me. I'll be happy to stop and go over things. If it's something that's going to take a little longer than I expect, I'll meet up with you at the end of the class. So with that, we'll get going. So I have about 90 minutes to go over these things with you. I want to go over with you lasers in cosmetic dentistry, the diagnosis of gingival aesthetic problems, procedures that can be done with the laser, and also procedures aesthetically that cannot be done with the laser. Lasers that you can, the laser treatment and solution is all just the only thing you do. There's no restorative dentistry after it. And then laser treatment that includes both restorative cosmetic dentistry and the laser. And then how to put those all together so that you can apply the best modality for your patient's best aesthetic result. And all of that, includes me enjoying dentistry quite a bit. And so I really love what I do, and I hope you do, and with you incorporating lasers in your practice, I think you'll, you know that also. So what I'd like everybody to get today, and what Roger Levin was talking about this morning, is that, we can't be a generic dentist anymore. And I think if I boil down what Roger was saying this morning is that you have to have some kind of unique properties, and those properties really need to be communicated to your patients to make your practice not only be profitable but enjoyable. So when I look at other businesses like grocery stores, they're all pretty much generic when it comes to these three in our town, and they compete mostly on price. So if a household can buy their paper towels cheaper at one, they might go there. Or if they buy their fruit at another and they're having a sale on it, they go there. But as a dentist, I try to encourage my staff and encourage other dentists not to be in that league of trying to do the cheapest filling in town or the cheapest crown in town and things like that. And so I invite you to pick up a unique proposition within your practice and communicate that to your patients so that they'll see you as different and come to you and value your services to them more than they would some other place that would be more generic. And Whole Foods is the one grocery store that my wife and a lot of other women here in San Diego enjoy because they have organic foods. And they talk about how the health of the food that they provide is better for your family. And so I think us with lasers need to bring how lasers bring better health to them and to their family if they come to our practices. And so really would like you to think about that and how you can bring lasers and communicate lasers and the benefit of lasers to your patients so they'll value you and enjoy your services to them and consequently want to pay a little bit more to have you serve them. So here's my practice. I'm the only dentist in my practice. We see one patient at a time, and we want to have a calming environment in my practice, along with some calming things in the operatories that don't necessarily relate to dentistry, like warm blankets, warm neck wraps, paraffin hand wax. And since we are seeing one patient at a time, we have time to get our patients ready before we see them and get them relaxed before we see their treatment. And of course, you can see the laser down on the lower left corner. I was fortunate enough to be on the cover of Dental Economics because of the technology and lasers I've incorporated into my practice. Tell you a little bit about my prejudices and where I come from as far as dentistry go. I'm a member of AACD and work towards my accreditation, and I'm accredited with AACD. I've served on their board of directors and currently serving on their education committees now. I believe in minimally invasive dentistry. I believe very strongly in fee-for-service dentistry. PPOs and capitation plans I don't think are in the best service of patients. And I believe in lasers, and I'm a real strong believer in BIOLASE because they've taken care of me as far as my education and servicing my lasers better than any other dental company has really serviced me throughout my career. So I was also highlighted with Dr. Levin's group in contemporary aesthetics and voted one of the cosmetic practices of the year 2 years ago too. So I was honored to get that along with my team. So the secret for me has been comfort, and that's what lasers are all about. And we can do things that normally hurt people in the past in terms of dentistry and make them comfortable. And one of the things that is wonderfully comfortable for me is when you can do a filling without anesthetic, or later on, as you see, do some gingival contouring or osseous contouring with a laser and make that whole procedure a lot more comfortable than doing something that is done with conventional periosurgery. So on our website, we have these different videos that, again, try to communicate the unique proposition of our office. We have lasers over there on the left, with the digital x-rays and an office tour in the center, some of our patient comforts. We do custom shading in our office. We have a porcelain oven in there. And we do digital pictures and intraoral camera communication. So again, some of the things that we like to have as a unique proposition for our office. And then we have one of those videos I'll just show you real quick that deals with the WaterLase.
One of the best things about our office is the lasers that we have. And one of the best lasers that we have is this WaterLase MD. And this laser helps us do fillings more comfortably. By using the laser, we can actually numb your tooth. The laser removes decay gently out of your tooth. It allows us to fill it with a tooth-colored material, all without getting that agonizing shot that comes with every filling that you get in other dental offices. We have 4 lasers here in our office, and less than 2% of the dentists in the country have these lasers. And so it's a huge benefit to our patients for them to come in, have a filling done. They don't need to get a shot. They leave and their lip isn't numb, and they can talk normally and resume their daily routine, all without having a fat lip. So this is the laser handpiece that we use.
You know all about that, so I'll go ahead and skip from there. But that gives a patient idea what our office is like and how they can expect to be more comfortable in it. So when they make that phone call and they ask about certain things, and they've called in other offices, they're more likely to choose our office, in my opinion, because we've communicated with them better before they've even come in. And so if you have a laser in your office, you need to figure out a way to get that story across to your people. So my belief is that laser dentistry makes things better in a lot of different ways. It takes ordinary dentistry and makes it extraordinary. It's minimally invasive, it's comfortable, it makes you unique, and it also is profitable, as you know or may be beginning to know. So let's just start with something real simple like gingival contouring to start our journey with aesthetics with lasers and cosmetic dentistry. So here was just a simple class 5 restoration that was leaking and decayed, and there was some subgingival extension to that, and so I did a gingivectomy first, cleaned it out, got to the extent of the decay with a slow speed, again doing this all without anesthetic and just topical, cleaned it out and did our filling, and the patient was happy with that. So there was actually a little bit more bleeding after I polished it than when I did it finished it up with the laser. So very common thing that happens in our practice, but again, a real simple thing that you can do to help your restorative dentistry along with your cosmetic dentistry. This is the topical anesthetic I use, but there's a lot of pharmacies that are putting this together in all different areas of the country, and I'm sure there's one in your area. So the handpiece, we've all seen that. But again, I can't get this point across more, is that this is what people think about when they're going to the dental office, a shot, a big drill. That's actually Bill Brown there as the dentist. You might recognize him. And that's what our patients think about. So we really have to change that kind of mind thought in our patient's mind and have them think something different when they come to your office. And so let's talk about getting ultimate aesthetics. And a lot of people think ultimate aesthetics comes from either the porcelain that you use, the lab that you use, or some trick that you have in your office that other people have. But really what it is it comes from planning your whole case out before you get started and having a vision of the way you want your teeth to look in that patient's mouth. And then planning to see if that would fit to their occlusion, and also planning to see if that would fit to their gum lines. And I continually bump into problems with patients' gum lines whenever I'm doing this, because we may want to extend an incisal edge a certain amount, but it wouldn't be enough to make the tooth proportional. And then when we look at the gum line's a little short, so maybe we can get a little length out of restoring their gum lines. But as you all know, when you go to move the gum line more than about 1 millimeter to 1.5 millimeters, you start invading the biologic width. And so that's where the laser comes in so handy. But the dentist has to have that vision of where things are and how they should look in their mind before he or she gets started, so the patient gets the best results. And so one year at the AACD convention, they had this picture and it asked you, can you picture perfect? And I thought that was a great question to ask yourself as a cosmetic dentist, is can you picture perfect in your patient so that you can execute as close to perfect as possible? So here's a case that I treated in my office, a police officer that came in, and he was going to be getting married in about 2 months. And he's always been very self-conscious of his teeth, and he wanted his teeth straight and white before he got married. So he had been into my office before, and then he put some money together and wanted to do this, but to do it in 5 or 6 weeks just wasn't going to be possible if we were going to be able to make these teeth the proper length and get the gum lines at the proper position. As you can see, there's a lateral and cross bite, and then some uneven gum on the lower. But with the laser and using some of the crown lengthening techniques that I've been taught here at the WCLI, we were able to give him the result that he was looking for when he got married. And so that's a pretty dramatic case, and I wouldn't recommend that someone try it in their first crown lengthening case, but it is something that is possible when it's planned out appropriately. So gum architecture is the other half of the story from porcelain and veneers and pretty teeth when you're doing restorative. And you have to understand that in order to get the ultimate result. So with the golden proportion of the gums, it gives us the background and the scenery of everything we're going to do, and making sure we get those gingival heights in the right place, and filling out the buccal corridor is what complements everything else we do to get that perfect smile, not just from a front view, but from a side view. So how many patients come in for aesthetic treatment in your office that need more than 1.5 millimeters of gingival recontouring? About 50% in my practice need at least one tooth that way. And I imagine it's like that in your office too if you look closely enough. And if you had a laser and you knew you can do it in your office, you would see it a lot more as it became evident in my practice. So whenever there's an aesthetic case, there's usually at least one gum line to move. And so this is the ideal position for gum lines as proposed by the American Academy of Cosmetic Dentistry. The centrals and the cuspids usually are on the same horizontal plane, with the laterals anywhere from 1 millimeter to 1.5 millimeters to 0.5 millimeter shorter than that. So that's kind of what we want to shoot for in order to get the perfect smile. And so a lot of us concentrate on the bottom half of the teeth. And so when we're doing an aesthetic case, we want to lengthen them. But what happens is most people have worn their teeth and ground their teeth and have kind of fit a shorter addition of their teeth. And if we go to lengthen them, it may look nice for a while, but it may not last. And so a lot of times we can get some length in the opposite direction to still give them those golden proportions without having to throw their occlusion off or risk the longevity of the restorative work that we do. And so I'm going to ask you not to look so much at the bottom half, at the embrasures and so forth, but kind of look at the top half of the teeth to help improve your aesthetic cases. So here's an AACD case that was done that I thought was done excellent. You can see the dentist looked at what he had or she had on the left and thought about, well, where do I need to put these gum lines and how can I get the gum line symmetrical so when I do this bridge replacing tooth number 7 to look nice. And that is an excellent result, and that to me is picturing perfect and executing it. So a lot of times the area that dentists forget is the buccal corridor. They want to get the 4 front teeth or the 6 front teeth and make them look perfect, but then it drops off into this black space in the buccal corridor. And so when we see that, we want to widen the buccal corridor. We bump into a problem is that we want to bring the teeth out laterally, but the length of the gum is usually short there. So the buccal corridor is another perfect spot to do some either gingival or osseous recontouring so that you can get the proper length of teeth in the buccal corridor. And so if you present that to your patients and show them what that looks like, even with just a mock-up of composite bonding, a lot of times they'll understand why that area is important and accept a case that is instead of 4 units or 6 units, maybe 8 or 10. So why haven't we offered the best gingival aesthetics to our patients when it comes to buccal corridor or symmetrical gum lines? A lot of it is because we were kind of stuck in the old paradigm of, well, if I send this patient out, I'm going to have to send him to the periodontist, and the periodontist is going to talk to him about gum surgery. And something like this is going to be in their mind where, they've done a full flap and have to do osseous resection and then sew them up, wait at least 8 weeks before they heal, and then possibly at that point, you might be able to do your restorative treatment. But what happens a lot of times is that the patient will either run out of money or run out of patience and don't want to go through the treatment when it's going to cost that much and they're going to have to go to a different office. And so they drop out and don't do the work. Or what is worse is, as a dentist, we don't even suggest it to them because we know that's the possibility, and I might lose my 4 or 6 units or 8 units, and so I'll just compromise the results. And then that's where we end up with short teeth or uneven smiles when it comes to gingival symmetry. But fortunately, with our lasers that we have now, we don't have to deal with that anymore. We can do it in our offices and not send the person out, keep the revenue in our office, and still get a perfect result for our practice. So I used to call this in dental school the perio penalty box because you want to graduate and do your requirements, but you had to send the patient to perio and you knew you would never get them back for at least a year, and by that time you should have graduated already. So the new perio penalty box is when we have to send our patients out to the periodontist for aesthetic cases. And since we don't have to do that anymore with a laser, I'm really glad I'm no longer in the perio penalty box. So here's a couple people that can benefit from better gingival aesthetics. One is Jennifer Aniston, one of my favorite people, but she shows a lot of gum line on a lateral view from the side. And the other is somebody that can surely afford it, Katie Couric, who has tooth number 8 that is square and like a chiclet, but still has never fixed it in her whole career. And so there's also another, Deborah Norville is another one that bothers me with how rabbit teeth she has, tooth number 8 and 9. So if these people came into your office and had a movie or had some kind of documentary they needed to do, and they needed to have their gums done in a couple, or and have their case done in a couple, 3 weeks, with a laser we can do it. And so it's nice to see that. So let me go over the one appointment WaterLase MD closed flap crown lengthening. I learned something yesterday from Dr. Brett Dyer. I don't know if any of you got to see him yesterday. But he says he doesn't do anything closed flap. And I've always called this procedure closed flap. But all of his are these tiny little envelope flaps, or he has some kind of periodontal explanation for it, but it's pretty much the same thing. If you want to see what you're doing with these, with the closed flap, you surely can by just holding the gum out and taking a look in there. But for my terms, closed flap is just fine for me because I'm not having to lay a flap. I'm not having to place a suture. So here is the attachment apparatus around teeth. There's a pocket, there's junctional epithelium, connective tissue attachment, and there's bone. And so if the tooth is up towards the ceiling and you want to make it longer from a gum line and you want to cut the gum, if you cut the gum more than 1.5 millimeters, you're going to invade the biologic width. And in fact, even at 1 millimeter, you're invading the biologic width. So if we want to make this tooth longer and not invade the biologic width without going incisally, we're going to have to remove some of the bone. And so I put this little animation together to kind of show you what that looks like with the PowerPoint. So here's the same slide, and then that orange line is our laser, and so we'll fire our laser and take away some of that bone. And then there's usually a ledge out to the buccal at this point. And so we can feel that either with the laser or a peria probe or a scaler. And you can just bring the laser out to the buccal a little bit and take that off. And then usually from there you can either round it with a laser or round it with a scaler, or whatever you prefer. And that's after you've done the gingivectomy. So that's how simple this is. And I'm not a surgeon, or have I been trained surgeon, and it came very simple to me. So here's a case of mine that has had a 5-year post-op. It may have been Chris Walensky 5 years ago that showed me how to do this, or it may have been another doctor here, but it was one of the first closed flap crown lengthenings that I did, and that's what her teeth looked like 5 years post-op. So if we put this natural biologic width back into place for the patient, and we treat all the other tissues well, it will stay and be healthy for a long, long time. A lot of dentists may have wanted to do veneers for this patient and kind of lengthen their teeth from the incisal, but it was absolutely the wrong thing to do. Just doing a little osseous closed flap crown lengthening, and the patient is perfectly happy and her teeth are perfectly intact. So that is great minimally invasive dentistry and minimally invasive cosmetic dentistry in this case. So here's a single tooth crown that needed to be done in my office. A very, very tricky thing that not a lot of us like to do, a single unit crown. But compounded to that is the fact that the two gum levels aren't the same. And since we're looking at this gum level, what do we see over here in the laterals? They're actually longer than the centrals. And so with this, again, with the laser, I thought, okay, well, I definitely want to make sure I have symmetrical spaces for my new crown here. But while I'm doing it, why don't I go ahead and get the rest of the gum line situated in a more appropriate way? And so we did that. And that's, if we have time, I'll show you the case step by step later. But that's the case finished. And we're wondering if this technique is stable. And that's 3.5 years ago that we did that. So paying attention to the biology really makes things last and stay healthy and not relapse. So here's another patient that I did. A 26-year-old woman with kind of a gummy smile and kind of square teeth. She actually happened to work for me, and she wanted to have veneers done on her teeth. But again, lengthening the incisal edge there to give the teeth the proper proportion, would start bumping into her lip, and it surely wouldn't correct her gummy smile. So again, knowing what I knew and knowing what I learned about closed flap crown lengthening, we proposed doing that for her. And then this is her after. So again, it gave her a more mature look, a more womanly look, rather than a 16 or 17-year-old girl that just got her braces off, that her gums are kind of overgrown. So again, no veneers, just closed flap crown lengthening. And again, as we do the closed flap crown lengthening, we're kind of working just from the 10 o'clock position on the tooth over to the 2 o'clock. So we're not messing around with the papilla, and we're just removing bone the appropriate amount underneath the gum based on where we want the gum to be at the end, based on where we see and what we picture as perfect. Any questions with that so far? Yes? Mm-hmm. You could do that. You could kind of do some kind of an exploratory type of procedure where you numb the patient and then you can measure her pocket depth and then probe through the attachment to the bone. But what I've been taught and what I practice when we're doing this is that each patient has their own individual biologic width. And so I'll pick some teeth that I'm either not going to work on or I numb and figure out before I work on them, and I'll measure their pocket depth, measure the attachment width into the bone. So then when I go to do the closed flap crown lengthening, I remove the bone and leave my predicted attachment width the same as what the patient had already. Because there's huge variations in biologic width with patients, and especially in the anterior area. It can be 2 or 3 millimeters different from one patient to another. So I recommend in doing this procedure is to take that patient's own biologic width and just plan on replacing it. So. No, this is with infiltrated local anesthetic, yeah. If you're doing gingivectomy, you can do that with topical. So this was, her name was Season, and again, we got her golden proportions, much better and much more mature look for her, without even touching her teeth. You know, we didn't take any enamel away, didn't put anything on there that needs to be replaced in 10 or 15 years. And so I feel really good about this kind of treatment. Even though it's not a $12,000 case, it's the appropriate case to do for the patient, and that's all we want to do in our practices. So there she is again. And then here's the testimonial that she did for us. I guess we're not going to hear it. But that was the same day that we did the surgery, and she talked about how comfortable it is. You can see we didn't use much anesthetic. Her lip was moving great, and she was not all worn out from a long, drawn-out surgical procedure. So here's another patient that has come into my practice, and I actually just finished her 8-day post-op Thursday. So this procedure is done often in our practice, and I think about it and use it a lot. It's something that I guess later on I'll tell you, I do about at least 8 of these closed flap crown lengthenings a month, you know, on different cases for different reasons. Sometimes it's a posterior restorative, but sometimes it's anterior. So Dominique came into my practice thinking about veneers, and didn't like certain spots on her teeth and the way her teeth were cockeyed here or there, but her teeth were totally intact. And so I put her through a series of Invisalign stents. And so we just finished her up in Invisalign about a month and a half ago. And she still didn't like some of the white spots on her teeth. And she didn't like, can you see if from that occlusal view on the lower left, how shoveled out the facials is of her? And that's kind of why she wanted veneers, is she didn't like that. And so I said, well, let's do the Invisalign first, see where the teeth end up. And then if you want to fill those in, that's just a straightforward bonding. And so that's kind of where we proceeded. And so I'm going to step by step kind of go through her case. She came back. That's her after her Invisalign. And her gums were short, and her teeth were square, and her laterals were real short. And so we just went ahead with a marker and marked where we wanted them and had them look. And one thing I advise to my male counterparts in the office is to have, if you have females working for you, to have them look at your patients, because they have a better eye than we do. Females actually have about 20% more recognition of color than we do, and the same goes for symmetry. And so I let my assistants, well, at least 2 of them, look at this before we've done. The same goes with shades, because I think something's one shade and they think they're another, and they see shades much better than we do, and that's fine. Let's use their attributes. And so we get this approved, and we ended up, instead of just doing the forefront teeth, we ended up doing a cuspid. And then the settings I use are there. It's 2 watts, 7 and 11, and sometimes it's on the soft mode, sometimes it's on the hard mode. That's the only thing I really change, and move the wattage up a half a watt here or there. And so we go ahead and we start doing the gingivectomy for her. And on the left is the gingivectomy done except for the cuspid, and then on the right is with the cuspid. And all of a sudden these teeth, you just kind of brought the beauty of the teeth out. They were always there, they're just being covered up by this curtain of gum. But in doing that, I've taken 2 millimeters, sometimes 2.5 millimeters of gum tissue off, so we can't really leave it like that. But again, that's exactly what it looks like when I'm doing it. It's not bleeding, and it's not a real gory procedure. And again, I'll show the patient that at that point and make sure she's happy with it. And then we take the handpiece and set it perpendicular to the root surface, and then just do the gingivectomy there and pull the gum off without lasing the root surface of the tooth. And then after that's done, we lay the handpiece parallel to the root, and again we work from this 10 o'clock position to the 2 o'clock position, and you'll just feel the laser kind of just dissolving the bone underneath there, and we just move it back and forth without generating any kind of heat, because sometimes with this tissue being real tight, you won't be able to get a lot of, the water sometimes may not flow underneath the gum as much as you'd like. And so later on you'll see a case that I did, and you'll see little brown things coming out, and that's the bone heating up too much, and so we'll have to turn the water up, I'm sorry. And so again, work from 10 to 2 with the bone, get that nice and smooth and shaped properly. And here is a video of that being done. Again, the laser tip is marked at the appropriate level, so I know exactly how far to go underneath there and not over-reduce bone, but usually the mistake is to under-reduce the bone. And so the cases I've had to retreat, all of them have been, I need to remove a little more bone. Yes, there's a question. This is a C9, I think, tip, and I just measure it 3 millimeters up with a Sharpie. Yeah. So here's that action kind of going on. And there's obviously some sound going on with that too, but you can actually kind of see the laser tip working with the aiming beam up here. Not so visible when you're as the operator, because you have a lot of light shining in here, but the camera picked it up very, very nice. And so it's just an up and down kind of sewing machine motion, and you'll feel little chunks of the bone going off, then you go back over and kind of smooth that with the laser in any of the little high spots. And then you may want to bring the tip out to the buckle to make sure you're not leaving a ledge, and if there is a ledge there, I usually just fire the laser a few times over that ledge to clear it up. But that's it. It's that easy with the WaterLase. And there's no dark burnt tissue here for my gingivectomy, and then there's no burnt tissue or burnt bone under the gum. A good periodontist friend of mine here in San Diego was once lecturing at the AACD meeting about 4 or 5 years ago, and he was lecturing on laser or perio cosmetics. And he saw me walk into his lecture, and he goes, "Dave, I have to tell you, I talk about you in my lecture, and so I just want to give you a heads up." And I got the feeling that maybe he wasn't going to say anything particularly nice, not at me, but at this procedure that he knew I was advocating. And he goes, "I just don't see how you can take a laser and put that hot tip under the gum and remove bone and think that that's healthy for the patient. And so that's what I'm going to talk about today. When I show you, my picture was in one of BIOLASE's ads, and he talked about it, and I go, Peter, you need to see what is being done with this laser. And so after the lecture, he came with me, we went over to and I showed him, it's not a hot laser, it's a cool laser, it's a water laser. That's why they call it a water laser. And fortunately, periodontists are starting to see that now, because they've always thought that any laser tip was hot and it was going to burn, and all this necrosis was going to happen wherever you used it, and it's just not true. And so it's nice to see a periodontist from Rancho Bernardo that's here. And I'm so glad to see a laser periodontist in San Diego. So, and then we have the president of the American Laser Academy was here too. And then the periodontist, Sam, speaking. So it's becoming more and more accepted, and I'm glad to see that. So anyways, after I've done that, I'll go over and feel along the root and remove any cementum that's not in the appropriate spot or that's on the root, or even sometimes take this scaler and I might, take the back end of it and smooth some of the bone or do a reverse bevel on the bone. And then check again with a perio probe to make sure that I've removed a bone. But as you can see, the teeth are looking very nice. I'm touching them and they're not bleeding. And so it makes for a great area to heal. And so here's after I've done some of the bonding to fill in some of those little shoveled areas. And then after you've kind of see things in a more perfect sense, you go, God, maybe I should have did a little gingivectomy up here, because I'm starting to see that now. We got everything else perfect, and all of a sudden you see one spot that isn't, so we did a little gingivectomy up on the gum line hover. So that's kind of how we treated Dominique, and I saw I was a little over-contoured here, and my incisal edges weren't quite symmetrical. So we had her back, and then these are her after pictures. This is her before we did Invisalign, and then this is her after. And after I was able to kind of get these incisal edges a little more symmetrical, and then this is 8 days after her treatment, and her gums are already looking very, very normal. And then her retracted view. You can see her lower teeth were improved quite a bit. We did some bonding, I think, down here and in a few other spots to get rid of the real obvious white spots. And then there's Dominique after. And again, I feel really good about this case because it was done minimally invasively. From orthodontics to bonding to laser gum treatment, it's really the best way to treat patients. So any questions with Dominique's treatment? Yes? I'm usually right at a little bit over 2 watts. It'd be somewhere between 2 and 3 watts. The central bone is usually a little thicker than the lateral bone, but then the cuspid bone is harder than the lateral and the central. So just depending on how it's cutting, I'll just move it up with that. Not at all. I leave them the same. And so, yeah, you just kind of get a feel of how it's cutting and go from there. Start off really low because you're just doing gingivectomies, and then it gets higher and higher because you're starting to do the bone. Anything else? Okay, let's go to, that's her after case from occlusal view. So here's the part that you don't want to do. Here's the part that needs to be conventionally done, or a combination of conventional surgery with laser. But if you're dealing with closed flap crown lengthening and you're going over 3 millimeters apically, it's not a good procedure for that. Number one, it starts to get really deep and hard for you to see and feel. Number two, the bone, as you go up that root, gets wider or out to the buccal, thicker out to the buccal. And so you'll have a trough, and then you'll have to trough again, and then you might get to where you are. And then how are you going to blend that bone into the adjacent teeth when the bone's that thick? It's not something you should do with closed flap. So again, the bone just starts getting too thick there, sometimes in the mandible on the buccal. around a molar, you know, the bone is really thick there, so you're not going to be able to take that much off and still blend it into the rest of the tooth. Sometimes on the lingual of the maxillary, you're not going to be able to do that. The other thing I limit it to is 1 or 2 surfaces. You know, maybe you'll do the buccal and maybe squeeze it into the mesial on a corner of a fractured molar, but you're not going to want to bring it from the buccal straight to the mesial on the lingual, because again, you can't blend that into the rest of the tooth structure without doing a flap, without taking some bone off the adjacent teeth. So it's mainly for 1 surface, maybe blended into a second. And so that's where I think the limitations are, and that's where I stop with this. And when I've talked to other doctors that do this, you know, they tell me at about 1.5 millimeters, they stop doing a gingivectomy and start doing something closed flap. 3 out of the 4 doctors will take impressions the same day, make temporaries the same day, I'm included. And I'll show you a case later that I did that with, because I know the gum's going to heal back in the right position and stay there. In fact, that single central crown is an exact case like that, where I made the temporary, took the impression, all of that the same day. One of the doctors likes to wait for healing, but obviously you know my opinion, and I just go right ahead and do the rest of my case. And again, it just takes a few minutes per tooth. And all of us used anesthetic for buccal infiltration for doing this on our patients. So those are some of the survey results from a laser roundtable that we did. So as you probably already know, when you compare this laser crown lengthening technique to conventional, there's quite a bit of differences. And one of them is cost, as you see in the first column. In my area, it's about $900 to do a crown lengthening around a tooth. And then, in my office, it's something that I do for $425. In a conventional perio situation, there's 6 or 8 weeks of healing that needs to happen. And you saw what Dominique looked like after 8 days. So I say they heal in a week. And then as far as impressions, it's at least 6 or 8 weeks, and a lot of periodontists want 12, especially for an aesthetic case. But again, I do it on the same day. And then I've had the conventional perio surgery done from bicuspid to bicuspid on my upper teeth. And I can tell you the pain is moderate to high. And there's a lot of swelling, and it's uncomfortable for at least 4 or 5 days. And they're swelling. But again, Dominique had none of that. And none of our patients have any of that trouble, as long as you keep the procedure to some of the limitations that I talked about earlier. So it's a great procedure to institute into your office. It has all these same benefits that I've talked about for you, and the revenue stays in your office for that. So any questions or comments on that? Okay, so you were trying to stay away from that. Yes, John? Yeah. I stay away from it as much as I can. I mean, maybe the mesiofacial line angle of the tooth, and I might blend it up and kind of blend the attachment into it, but I'm trying not to take any bone from the mesiofacial line angle of that papilla, because that's where the support is, as you know. Do you find that you do something different with that procedure? Or are you a little more...
It's very similar to what you were doing, but I was just wondering what your guidelines, because there are a lot of people who say different things, and it's just kind of like, it's good to have kind of a mental picture as to where you're trying to go with that laser tip and what you're trying to sound the bone with either a periolar or the laser tip.
Yeah, I guess as I'm coming around that, sometimes you'll feel a big step that comes up to the papilla, and I feel comfortable enough to blend that step. tooth number 8, you come up there right at the line angle, there might be a big step, so I might just blend it a tiny bit. But I'm not trying to get underneath that papilla at all. Once it gets into the mesial portion of it, I just leave it alone. There's usually no reason to, also. If you're going that deep, then usually you're doing a veneer and you're going to go in there interproximally anyways to close a black triangle. But, all right. So some of the people that advocate the closed flap crown lengthening are some of the clinicians that we know. David Hornbrook, Frank Spear. A lot of people like this and are teaching this in their aesthetic continuums too. So for me, it's really the right thing to do. And as I tell a lot of the dentists in my area when they ask me about it, is that if you don't have a waterlase to do this with, I would find a periodontist or a dentist that you would send your patients to rather than have them go and get flapped, conventionally. If it were my wife, my sister, my brother, and I didn't have a waterlase, again, I'd find somebody, even if they had to drive up to Orange County to have this procedure done, because it's the way to do it. It's minimally invasive, and it doesn't cause any harm, or at least not the harm that the normal conventional surgery does. So again, minimally invasive laser dentistry. One of the things that I'll share with you that the American Academy of Cosmetic Dentistry is advocating, and if you keep up with them at all, is that their next meeting, the name of it is called Responsible Aesthetics. And the board and the leadership there is advocating doing things in a minimally invasive way and not just grinding teeth down to make them look pretty without investigating all the other things that are consequential to that. So we all need to bring that into our practices, whether we're practicing cosmetic dentistry or restorative dentistry, is trying to do things in a minimally invasive manner. And so many of the instruments, and especially our lasers, are so good at that. And I really feel good about being a member here of the WCLI and a member of the AACD when they believe that. And so it's nice to see that, and it's nice for me to bring lasers into cosmetic dentistry, and then also have other disciplines start thinking this way. So these are all the different things that could be done with the laser to help with cosmetic dentistry, from doing a no-cord technique, localized crown lengthening, multiple teeth crown lengthening. As I showed you that 5-year case, that was 8 teeth that we did crown lengthening on. Correcting gummy smiles as we did with Season. I'll show you a buccal corridor treatment later on. And then there's even cases where two centrals were done and they invaded the biologic width. And in replacement of those 2 centrals, I corrected the biologic width with the laser and placed new centrals, and the gums are perfectly healthy after that. So a lot of things, and then more and more people like Ed are doing things with implants, and the implants are blending into aesthetics and vice versa. So it's multi-dimensional what the laser can do. So here's some cases. Not to just talk about front teeth, but talk about back teeth. This is Dr. Lowe's case that he published in a journal that showed where there was biologic width invasion from caries. He went in with his laser and removed some bone in a diagonal manner here. Got the appropriate distance from the margin of the crown, and then went ahead and did the restoration. And so that's the basis of some of the things that I do in the back part of the mouth, was learning from clinicians like him. So here's my version on a palate of a lingual cusp that was fractured. Needed to do endo. Did a closed flap crown lengthening on the palate to get enough margin for our what turned out to be an onlay, and then did our onlay. And so if you had this tooth in your office, you did the endo, then you had to send it out to the periodontist for the crown lengthening, then wait the 2 or 3 months. It just doesn't make sense if you have a laser in your office. And so it brings quite a bit of revenue to your office in a very short amount of time, basically the length of time it takes you to do the buildup in the crown and the endo. And then some of my colleagues have CERAC in their office, and they can probably do this all in one day. But I don't have a CERAC. So imagine combining those two things. So here's a case where a tooth had broken off near the gum line, and we had access to the distal of it. So I decided to do more than my 1 or 2 surfaces on this tooth. So again, we do the gingivectomy first, remove gum tissue, and then do the bone removal to the appropriate biologic width. And we probably, what it looks like we went about 180 degrees around this tooth, but because I had distal access and we're planning implants for the back, that's how it worked out. And obviously I have enough tooth to work with now. And then there's our crown. So again, something that generates about $3,000 worth of treatment in our office in a very short amount of time, and is a benefit to the patient. It's not like, I just want to take these high fees from patients. It's a huge benefit to the patient not to have to go to another office, pay another doctor, and wait 8 weeks to heal. So it's a win-win situation. So here's a case that was referred to me from an orthodontist, where this patient had 6 veneers placed previously, and she was entering a Mrs. San Diego contest. And so she wanted to come in and have her veneers replaced because she didn't like the looks of them. They were bulky, as you'll see later. It's kind of what they look like close up, very bulky, not much embrasure spaces between them. Really kind of convex on the outside. And then what happens to her buccal corridor when these get bulky is that you actually accentuate her kind of somewhat narrow arch form. And so I talked to her about not only replacing those veneers, but treating the buccal corridor and then actually kind of lengthening them a little bit because she was a little gummy on one side. So we went ahead and did that for her. This is more of her pre-ops. And then this is her treatment. These teeth are kind of speckled because I removed her veneers with the laser. And I'll show you that, a little bit of that, a video done by another doctor. And then all I did is basically smooth these out. And then these are her temporaries. But we filled out her buccal corridor and then did a little gingivectomy to try to level her gum lines from right to left. So those are her temporaries there. And then here's the video of laser veneer removal. How many in the room have done this? Yeah, so nice procedure. And again, very minimally invasively, because as you fire the laser energy into the porcelain, you start seeing these fractures, and it starts separating the veneer right at the cement tooth interface. You need to use higher power. In fact, I use somewhere around 6.5 or 7 watts with this. And then a lot of times this just pops off, or with just a little bit of a tug from an Explorer, you can see the veneer just come off. Dr. Jesse, who's doing this video, actually is, I think, going slow because he kind of wants the camera to pick up these fractures in the veneer. But more and more of us are replacing veneers that have been done in the last 10 years. And then this is a perfect way to get them off quickly and at the same time getting them off minimally invasively. So a really, really good procedure. See, I think I bring it down to about 20, 15, yeah, because you have to go a little shorter hertz to get the power to it. And it won't let my wattage get up. Is that right, Chris? Unless you bring down the hertz. So that's that. But this is her before smile. And again, it doesn't look too bad, but look at how natural these shapes are and the embrasures are compared to kind of this real convex, over-contoured look. And look at how her buccal corridor looks now that the veneers were done on the bicuspids and we've leveled the gum line. And again, a lot of people don't notice their smiles until you start showing them pictures, but you can see how her lip comes up higher on her left than her right. And so this asymmetry of gums and the buccal corridor is accentuated on her left side. So that is Virginia's case. And I thank San Diego lab, Downtown Dental Designs, for doing the porcelain work for me for her. And then this is her before and this is her after. Unfortunately, she didn't win the contest, but she felt a lot better about it. So let's go over that single central again that we saw and go through the procedure for her. This is Debbie, and as you saw earlier, there's asymmetry of her central gums, along with some kind of erratic gum lines of the laterals that don't match the centrals to what we would consider appropriate in cosmetic dentistry. So her lateral gum is longer than her central, which it shouldn't be, which makes this tooth look really long and narrow, and it actually makes this tooth look very square. So if we bring these gum lines up, these teeth will look more natural and better, they'll be better looking, and then these other gum lines will be more symmetrical. So the way I did this one was just place a piece of floss across the way and then made some little puncture areas along the gum just to kind of demonstrate different ways that you can mark the gum. I marked it with a blue pin, I marked it with a laser here, or you can get it started with some floss. But here I'm lining it up, making my marks, and then starting to do my gingivectomy. And as you can see in this picture, all of a sudden you do this gingivectomy and all of a sudden these teeth start looking better, even though, you know, our shade's off here. But you can see how the proportions are improved. So we do the gingivectomy here, holding the laser perpendicular. And then we take these little crescent moons of gum tissue off. We did this other central because we wanted to line these gums, the level of the gum up better to match this lateral, so it wouldn't look so funny. And that's kind of what it looks like. And at this point, you almost think you're finished, but you know, we have to do the bone. And so that's what we're doing there on the bottom right. Again, the marks on the laser. And then this is the before and after of Debbie. And as I told you, she's 3.5 years post-op now. And when I look at this case, I think the gums look fantastic. I'm very proud of that. But you always can make this porcelain better. It took me longer to get this porcelain right than it did the gums. But single centrals are hard enough without having asymmetry there. So making it symmetrical first surely helps. Okay, here's another orthodontic case where the patient had a pegged lateral, and then her other lateral was misshapen. It kind of was square if you looked at it from the incisal. And this is Alex, and she's 15 here, and just getting her braces off, I sent her back to the orthodontist to push that tooth more lingually because it was kind of laying against the wire. And if I was going to do a veneer of some type on it, I didn't really want to take any enamel off. So we pushed it in, and then this is kind of how she got. But you can kind of see how gummy she is. And in my original diagnosis, I talked to her mom about doing her bicuspids also. But they were just meeting me, and I was just talking to them about a procedure that they have never really heard of. And so they just elected to do the 6 front teeth, which is fine. But at least I presented the buccal corridors for her and the gingival display up in that area. So we end up doing 2 veneers for her, number 7 and 10. And so again, this is the same day, did the crown lengthening on 6 teeth, including the 2 veneers that we did. We made her temporaries, and we also took her impression. What's really important with these temporaries is showing your lab how you want them shaped from a facial contour, along with showing them the kind of embrasures you want in the incisal. And so we work on that quite a bit, Eddie and I, my lab tech, so that when I give him an impression of the temporaries, he mimics the exact incisal embrasures that I have. And then usually he does a much better job on the facial contour than I can do. So he'll do a better job out here than I do in the temporaries. But I really want him to have a good idea of length and the shape of that incisal edge. And so that was her temporaries. And then she came back 3 weeks later, and we cemented her case, and this is her finished. And again, a real feel-good case here, because shortly after this, she goes to the prom. She has her braces off, and then she has those 2 teeth that were kind of misshapen and fixed, and she just kind of blossomed into a beautiful young lady. So it's a good feeling. So any questions at this point? How are we doing time-wise? After, okay. Then let me just go over a few more cases. I was thinking we'd be ending about now. No, it doesn't look like that's going to wink. Okay, my cases aren't on here, so we're going to be ending at this point. But what I want to, again, emphasize to you is that your practice is the thing that lays the golden egg in your life. You have a question? Of the policeman, some of the details? Sure, let me go back to his pictures. I don't have his case all out. But he had lingual, some of his teeth were thick on the lingual as they were blended towards the incisal. So their lingual position really didn't change at all. No endo. Amazing how little endo is done in what they call instant ortho with veneers. But no endo for him. So here's his case first. And so what we did for him is we knew what he wanted. And we wanted to see if we can match timing-wise what he wanted, also match it restoratively. So we took impressions. My lab tech and I did a wax up, reducing, distals of teeth and so forth, and brought the teeth into position, and to see what they looked like if we narrowed the teeth enough to bring them not only fixing a crossbite, but correcting the incisal edge height and so forth. And so we did that. Then we did templates of that so that I can use them as prep guides. And so we had a template coming from the lingual and a template coming from the buccal, and then we had a template we used from an incisal edge. And so we used that all as prep guides. And we saw that we'd be able to do the case restoratively. We didn't know whether we'd bump into endo, but we frankly didn't bump into any pulps, which is great. He was 34 years old, so not a young person. And so I used those in doing our preps. And then we used the wax up to make our temporaries. But a couple things need to be done with the wax up, because if you just do the wax up after you've kind of prepped the teeth on stone, and then you use your templates on that, they won't fit in the mouth, because the teeth are going to be sticking out in different areas. So we had to do the wax up from the buccal first, and then do a template from the lingual so we can see it, and then vice versa. So that as I'm prepping, my templates work on the teeth that haven't been prepped yet. And so that was a little tricky also. And then we made the temporaries and made sure he liked the temporaries, and the temporaries were proper orientation horizontally and buccolingually, and that he was happy with the aesthetics of them. And then we took impressions of that, used that as our blueprint to make our permanents. But complicated, but he was a great patient. He spent 3 good mornings with me doing that, and that's how he turned out. Right here, there is kind of some thicker porcelain that you might put a ledge on, like if you had an implant that was lingually placed. Same thing over here, but generally that's what it looked like. The other thing you need to do in order not to have real thick incisal edges is you kind of have to prep a lot on the lingual towards the gingival so that you can blend your porcelain up into a thin edge. And again, I say they're thick, but they're mainly thick from the mid-body down to the gingival. So that's how that case done. If you'd like to see it, I don't know if I have it on this computer, but I can show you interop pictures too. So any other questions? All right. I appreciate your attention. But last is your golden goose, which is your practice, is that you need to take care of your practice. You need to invest in your practice. You need to improve your practice so that your practice keeps laying these golden eggs. My practice supports, my family. It supports our vacations, and it supports 4 other families within my practice, that are the people that work for me. And so we have a tremendous responsibility to take care of these practices. And practicing dentistry is one of the most wonderful things in the world as far as I'm concerned. There'd be nothing better that I'd want to do. Allows me a 4-day work week, allows me to go on vacations when I want to with my family, allows me to spend time with my family after work. And so I just encourage you to take care of practice and invest in it and learn laser dentistry as a way of improving your golden goose. So if there's not any other questions, my presentation is over, and thank you for your attention. Let me go over the code with you.